Most doctors treat the body. Neurosurgeons operate on the part that makes you, you, your speech, your memory, your movement, your personality. A mistake measured in millimeters can take someone's ability to speak, to walk, to recognize their own family. And the road to being trusted with that starts years before you ever touch a scalpel. Level 1. Medical student. You're 22, first year of medical school. You were the top student somewhere. So was everyone else in this room. That stops meaning what it used to. The first 2 years are classroom and cadaver lab, anatomy, pathology, pharmacology. You dissect a human brain during neuroanatomy. You hold it in your hands, and it's heavier than you expected. Every memory that person ever had, every word they ever spoke, every face they recognized, you're holding it. It weighs about 3 pounds. Third year, you rotate through the hospital. Surgery, internal medicine, pediatrics, psychiatry. On your neurosurgery rotation, you scrub into a craniotomy for the first time. You stand across the table, holding a retractor for 6 hours. Your arm goes numb around hour 3. The attending barely looks at you, but through the microscope, you can see the surgeon separating a tumor from the brainstem, millimeter by millimeter, and the room is completely silent except for the monitors and the hum of the bipolar forceps. You decide right there. You don't fully understand what you just decided. Neurosurgery accepts about 240 residents per year across the entire country. 379 people applied last cycle. You need board scores in the top 10%, a stack of published research papers. Most competitive applicants have 10 to 20. And letters from neurosurgeons who'll vouch for you by name. Some students take an extra research year just to build a strong enough application. You're adding a year to a pipeline that's already the longest in medicine. Match day. One envelope opened in public, surrounded by your classmates. Some of them are crying. You read the paper. You matched. You're 26 years old. You won't operate independently until you're at least 33. Your college friends who went into tech are making $200,000. You owe $215,000 in student loans. You go home and start packing. Level 2. Junior resident. You show up day 1, 5 a.m. The chief resident gives you a list of 15 patients. You pre-round on all of them before the attending arrives. Check vitals, adjust medications, write notes, flag anything that changed overnight. By 6:30, you present each patient in 60 seconds or less. Get to the point. Don't waste their time. Your salary is $63,000. You'll work 80 hours a week, officially. Neurosurgery is one of only a few specialties with a special exemption allowing up to 88. Before 2003, residents averaged 110. The culture remembers. You're the bottom of the hierarchy. You hold retractors, you close wounds, you place external ventricular drains, a catheter threaded through the skull into the fluid-filled chambers of the brain to relieve pressure. You do the work nobody else wants to do, and you do it on 3 hours of sleep because the trauma pager went off at 2 in the morning and somebody came in with a gunshot wound to the head and you were the one who answered. The glamour disappears fast. Your pager goes off, and it's a headache consult. You walk to the ER, evaluate the patient, and it's a migraine. You walk back, your pager goes off again, another consult. You walk back. This happens 4 or 5 times a night on call. Between consults, you're writing notes, fielding questions from nurses, managing post-op patients who are confused or in pain, or pulling at their IVs. You eat standing up. You check the clock, and it's 2 a.m. You check again, and it's 5:30, and rounds start in an hour, and you haven't slept. You learn to function like this, not well. You just learn that well isn't really the standard. You start drinking more coffee than you ever thought you would. You eat whatever's closest. Your posture gets worse. 3 months in, your first patient dies, a ruptured aneurysm. She came in unconscious and never woke up. The attending calls the family. You stand in the hallway outside the room and listen to the sound through the door. Nobody debriefs you. Nobody asks if you're okay. You have a case starting in 20 minutes. You drive home after a 30-hour shift. You don't remember the drive. You'll think about this later, that you were operating a car on public roads after 30 consecutive hours of work. And you'll realize that every neurosurgery resident you know has done the same thing. 2 more years pass. Level 3. Senior resident, chief year. 5 years in, something's changed and you're not sure when it happened. A CT scan comes up on the screen and you see the problem before anyone says anything. A junior resident presents a case and you already know what the attending's going to recommend because you've seen this exact situation 30 times. You're not guessing anymore. You're just slow enough to still double check and fast enough that the double check only takes a few seconds. The attending hands you the drill, you make the burr holes, you cut the bone flap, you lift it, and the dura is right there, the tough membrane between the skull and the brain. You open it, and the brain is pinkish gray, wet, pulsating gently with each heartbeat. You're looking at it through the microscope at 6 to 40 times magnification. A field the size of a quarter fills your entire visual world. Your hands are in the field now. The Penfield dissector separating tissue, the bipolar forceps cauterizing tiny vessels, the suction clearing the path. The attending is in the room, but increasingly as a coach, watching, occasionally guiding, mostly just there. Music is playing in the background. Everyone in the room knows that if the music stops, something went wrong. Chief year. PGY7, you log 400 to 500 cases. You manage all emergency neurosurgery and in-house consultations. Junior residents come to you at 3 a.m. with questions you remember having yourself. You've been in training since you were 18. You're 32 or 33 years old. You earn $79,000. A nurse practitioner with a 2-year degree makes more. Your college roommate just bought a house. You're still paying interest on loans you took out a decade ago. None of this is new information, but some mornings it lands differently than others. On your last day of residency, the attending pulls you aside and says something like, "You're ready." 2 words, 7 years compressed into 2 words. You strip off your gloves and walk out of the OR for the last time as a trainee. Fellowship starts in 6 weeks. Level 4. Fellow. You're already one of the most highly trained physicians in any hospital in the country, and you're still not done. Fellowship is where neurosurgery splinters: spine, skull base, pediatric, vascular, functional neuro-oncology. You pick one. Each has its own cases, its own risks, its own way of keeping you up at night. Spine is the most common path and the most lucrative. A high-volume spine surgeon in private practice can clear $1.5 million a year. Skull base is among the most technically demanding surgery in all of medicine. Tumors wrapped around cranial nerves that control vision, hearing, swallowing. You remove the tumor and try not to take those things with it. And then there are the operations that feel closest to science fiction. Deep brain stimulation. You implant electrodes into specific brain nuclei, often with the patient awake. For a Parkinson's patient who's been shaking for 10 years, you turn the stimulator on and the tremor just stops. Their hand goes still. They look at it. Some of them start crying right there on the table. Awake craniotomy. The patient's skull is open. You can see the brain. The patient is talking to you. A neuropsychologist asks them to count, name objects, read words aloud. You touch the brain surface with an electrical probe, and the patient stops talking mid-sentence. You've found the speech center. You know exactly where you can't cut. You pull the probe away. The patient starts talking again. You continue removing the tumor while they tell you about their kids. One patient at Mayfield Clinic never stopped talking during the whole procedure, chatting about college, her biology courses, her dream of becoming a physician's assistant. Another patient was told it was the neuropsychologist's birthday and launched into happy birthday while her brain was exposed on the operating table. You're 34 years old. You've been in training for 16 years. Your friends outside medicine have houses, retirement savings, established families. You have a fellowship salary of $80,000 and loans that have been quietly accumulating interest the entire time. Level 5. Attending neurosurgeon. Nobody says, "Let me check with my attending" anymore. You are the attending. You consent the patient. You explain what you're going to do inside their skull, what the risks are, what might go wrong, what happens if you do nothing. Their family sits across the desk and you can see them deciding whether to trust you. You sign the form. You scrub in. Your first solo craniotomy. No senior surgeon in the room. The drill bites into the skull. You lift the bone flap. Everything you've trained for, 7 years of residency, 2 years of fellowship, thousands of hours, comes down to your hands in this field, right now. You begin. The money finally arrives. Academic neurosurgeons make $400,000 to $600,000 a year. Private practice can push past $900,000. You also carry malpractice insurance that runs $30,000 to $300,000 a year, depending on the state. Because more than 80% of neurosurgeons get sued at least once over a career. You try not to think about that part during a case. 2 years in, you have the case. Every neurosurgeon has one. A vessel you didn't see, or a tumor that bled more than expected, or a patient who went in speaking and came out unable to form words. You did everything right. Or you think you did. You replay the operation in your head for weeks, looking for the moment. Sometimes you find it. Sometimes there's nothing to find, and the outcome was bad anyway. You have clinic the next morning. You go. You smile at the patients. They don't know what happened yesterday, and there's no reason they should. You're 40 years old. You're one of roughly 4,000 board-certified neurosurgeons in the entire United States. You work 60 to 80 hours a week. You take trauma call, which means a phone that can ring at any hour. A ruptured aneurysm, a subdural hematoma, a child who fell off a trampoline, and when it rings, you go. One neurosurgeon put it this way: do I miss not having been at the soccer games for my kids? Do I regret having missed the plays? Of course I do. I'm a dad. But if I wanted to be a neurosurgeon, I knew I had to make those sacrifices. When the decision goes right, someone walks out of the hospital. When it goes wrong, you sit in a room with their family. Some weeks, both of those happen on the same day. Level 6. Chair, pioneer. 25 years in. You operate maybe 2 days a week now. But these are the cases nobody else will take. Skull-based tumors that 3 other surgeons called inoperable. Families who traveled from another country because someone told them you were the only one. The rest of your time looks nothing like surgery. You run a department, 20 to 30 neurosurgeons, a residency program, research labs, a budget in the tens of millions. You spend a surprising amount of time in meetings about things like parking allocations and OR block scheduling. You recruit faculty, negotiate with hospital leadership, decide what the department will work on for the next decade. You review 300 applications for 3 residency spots. You read a personal statement from a 27-year-old who reminds you of yourself. Same intensity, same conviction, same complete ignorance of what it'll actually cost. You remember being that person. You rank them number 1. Not everyone at this level looks the same. Harvey Cushing, the father of neurosurgery, reduced brain surgery mortality from 40% to under 8. He also won the Pulitzer Prize for a biography he wrote on the side, because apparently saving the field of brain surgery wasn't enough. Henry Marsh spent decades at the top of British neurosurgery and then wrote a memoir about the patients he harmed and the mistakes he still thinks about at night. Paul Kalanithi was a chief resident at Stanford when he was diagnosed with terminal cancer at 36. He went back to the operating room during a remission, scrubbed in while on chemotherapy. His attending described watching him operate as the most remarkable thing I have witnessed in medicine. He died at 37. His daughter was 8 months old. The field you entered is barely 120 years old. Techniques you pioneered are already being replaced. The next generation will do things you can't imagine. Your hands aren't what they used to be. You've noticed it. Nothing dramatic, just a slight change in the morning, a steadiness that takes a few extra seconds to settle. Under a surgical microscope at 40 times magnification, you'd see it. You're not sure anyone else has noticed. The American College of Surgeons recommends voluntary assessment starting between 65 and 70. Voluntary. Nobody tells you when to stop. You look at the list of cases for tomorrow. A 14-year-old with a brainstem glioma. The family flew in last night. They're in the waiting room already. You put on the white coat and walk down the hall. Somewhere, a 22-year-old medical student is scrubbing into a craniotomy for the first time. She's holding a retractor. Her arm is going numb. The attending hasn't looked at her once, but she can see through the microscope A surgeon's hands moving inside a human brain, separating tissue from tissue, vessel from nerve, tumor from the thing that makes a person who they are. She doesn't know what it'll cost. Not the 30-hour shifts, not the patient who doesn't wake up, not the family she'll have to face afterward. She's watching the hands. She's deciding,